So far we have been lucky, in fact, that our standard treatments, one size fits it all, was more efficient than quite a couple of number of solid cancers. However, this has changed now, and I just will give you two examples, one in acute myeloid leukemia, the other one in lymphoma. Acute myeloid leukemia, well, so far we just applied brute force high-dose chemotherapy, and that achieved some cure. But what we've learned just during the last 5 years or so, that with targeted therapy we might overcome the disease. Applying hypomethylated agents, you're switching the gene expression of the malignant cell, and by that, surprisingly, even in such a highly aggressive clinical course of acute myeloid leukemia, you may see remissions and even long-term success. So how can we predict which patient will respond to this approach? We have seen some data suggesting that you will be able to predict response just by specific gene expression. And that would be really open the door to finally what you might quote personalized medicine, even in acute leukemia. On the other hand, in lymphoma, currently it's fair to say there's a revolution going on. So far we have been quite successful with standard chemotherapy complemented by targeted anti-CD20 antibodies. However, now we really learned during the last couple of years that even highly aggressive lymphoma are still dependent on the B-cell receptor. And by targeting, inhibiting these B-cell receptors, it's quite striking that even in these very advanced malignant diseases, you might be able to achieve remissions and even complete remissions. And what we've learned just recently by targeting these specific pathways, the sensitivity of the cells is also dependent on both the nature of the cells or of specific mutations. So, yes, so far personalized medicine was a minor theme in hematology, but things are just starting to change. In previous times we have applied, if you want, so unspecific kind of chemotherapy. So yes, we do have some prognostic markers in the specific kind of diseases. Some of them biological, namely cell proliferation, some of them even molecularly. And in fact, in acute myeloid leukemia, we are really able to identify the specific molecular risk factors. However, things have changed. Now, as we are moving to targeted approaches, and in fact, now we have to explore really predictive markers in that way that we have to identify which patient is specifically prone to respond to one or another targeted approach. Surface markers play a very important role in the not only classification of hematological malignancies, but also into identifying risk profile. So in fact, it has been 20 years since we applied immunohistochemistry to differentiate different lymphoma subtypes. In addition to this classification tool, we now also apply these as a risk predictor. For example, in aggressive lymphoma, we do know that cases with specific gene or marker rearrangements, and that might be BCL2 coupled with MYC, and thereby imbalancing two pathways, namely the proliferation and the cell apoptosis, we really can now identify higher risk cases upfront. In addition to these tools in leukemia, we already know for quite some time that cytogenetics plays a crucial role in planning the specific treatment strategies. In addition to that, during the last 10 years or so, we're not only looking at whole chromosomes or even chromosome bands, but we're looking at distinct genes, really identify the individualized disease risk. we had the concept of immunotherapy already since decades. And one example, in fact, is allogeneic transplantation acute myeloid leukemia. This approach only works by transfusing a foreign immune system which finally attacks the tumor cell. Now, this is unspecific immunotherapy. In contrast, during the last 20 years or so, antibodies to specific surface markers have revolutionized the therapy of malignant lymphoma. An anti-CD20 antibody, and I have to add CD20 is expressed in the vast majority of malignant lymphoma, is very sufficient improving even the long-term outcome. So now essentially this anti-CD20 antibody rituximab is improving overall survival in 90% of our patients. Currently, we are building on these achievements and try to develop second, third generation antibodies which more specifically target the cell. And I really would like to refer to one specific approach, which is, I would say, to amplify the efficacy of antibodies by conjugating either radioactive compounds, that had been the old principle, or by chemotherapy. And thereby really having a toxic agent which is brought to the cell, internalized, the toxin is relieved and is destroying the cell from inside. We now really have specific tools to destroy the malignant cell without really bringing the normal cells into danger. Having said that, I'm afraid of all, although I strongly do believe in all what we've learned about basic science and molecular pathogenesis of this kind of disease, at the end of the day, we still have to test these compounds in prospective trials to really define efficacy, toxicity, and feasibility.